Under the foot, we have a thick fibrous band called the plantar fascia. It supports the foot arch and stabilizes the foot when you stand, walk, or run. The inflammation of this band is called plantar fasciitis. People often describe it as when I get out of bed, the first few steps feel like I'm stepping on a sharp stone. The fascia shortens slightly during rest or sleep. The first step in the morning stretches it suddenly, which reactivates pain. Or people say, if I sit for a while, when I stand up, my heel screams for the first minute. It's right here inside the bottom of my heel, pointing the heel pad. It eases a bit as they move, but after a long day, it comes back worse. They focus on the sharp, stubborn pain first thing in the morning after rest. Later in the day, it can turn into a dull ache or a tired feeling. The plantar fascia gets injured when starting intense walking, running, or jumping without gradual warm-up, or when standing all day like teacher, retail workers, or factory workers, because long standing and repetitive load injure the fascia. Some people have flat feet or very high arch, both of which overload the fascia. Overweight, obesity, and pregnancy are also important risk factors because they increase strain on the feet. After age of 40, fascia elasticity decreases and the risk of inflammation increases. Repeated impact adds to microtrauma, causing tiny tears that appear faster and heal slower. As a result, every step sends more shock into plantar fascia attachment on the heel bone. Plantar fasciitis is usually in one foot, but can be in both feet. During physical examination, pressing on the inside bottom of the heel is tender and painful. Lifting the big toe upward while standing or sitting can trigger heel pain. Nerve symptoms should not be present. No tingling, numbness, or burning. There should be no joint swelling or multiple joint involvement, which are more likely in systemic disease like rheumatoid arthritis. In plantar fasciitis, pain is spread over the inner heel area, but the patient cannot pinpoint one exact spot. Most cases don't need imaging. Diagnosis is based on symptoms and physical exam, but on ultrasound, the fascia appears thickened, more than 4 millimeters, with dark hypoechogenic changes near the heel bone. On X-ray, heel bone spur may be seen, but this does not prove plantar fasciitis, as many people with Spur have no pain. Heel bone spurs are reactive bony growth at the fascia insertion. They develop from chronic pulling or repeated compression. Spurs can occur with or without symptoms. The pain usually comes from fascia tissue, not spur itself. Modern guidelines emphasize that plantar fascia is often a degenerative fasciopathy rather than an acute inflammation, especially in chronic cases. If both heels, heart, and other joints are affected, doctors check for systemic inflammation and arthritis and metabolic conditions. First-line treatment of plantar fasciitis is exercise, load modification, footwear, orthosis, and sometimes medications. Stretching is most important. Plantar fascia stretch. Sit, cross legs, grab your toes, and pull them back towards the shin for 30 seconds. Second exercise, calf stretch. Stand facing wall, one foot back, heel down, lean forward for 30 seconds. Do this 2 to 3 times daily. Reduce activities that overload the fascia. shorten standing periods, avoid running or hard surfaces, spread activity instead of doing long sessions, replace high impact with low impact exercises like cycling, swimming. Footwear is also important. Choose good arch support and shock absorption. Avoid thin flat shoes or worn out sneakers. Use shoes inserts for comfort. Foot taping is also important. Rigid or elastic tape supports the arch and reduce strain, usually worn during the day for 6 weeks. And night splints is important. Keep the ankles and toes slightly bent upward and prevent fascia shortening overnight. It can be used for 3 months if morning pain is more problem. And from medication, pain relief is important, but they don't cure the condition. Ibuprofen is most commonly used 400 to 600 milligrams every 6 to 8 hours. Naproxen up to 500 milligrams twice daily. Its effectiveness is around 70%, and typical course is 3 weeks, but we should consider the gastrointestinal side effects and bleeding risk sometimes. Topical non-steroidals like diclofenac gel can be used 3 to 4 times daily, and acetaminophen if person has gastric problems. Corticosteroid injection like triamcinolone or methylprednisolone can be used, but single injection to avoid fat pad atrophy. Platelet-rich plasma injections, 1 to 2 injections for 6 weeks apart. It's effective, but in chronic cases, but not first-line treatment, and it's expensive. And nitroglycerin patches, 2.5 milligrams daily, possible they have some benefit in chronic cases, but not well studied.